Hi, I'm Jack Cush, Executive Editor of RheumNow.com, and this is the RheumNow Week in Review. This week on the website, a lot of interesting information, starting with the Arctic study. The Arctic study is actually a study that looked at what happens when you use a treat-to-target strategy, but now you insert an imaging outcome. As we know, there are many different definitions of remission, CDI remission, DAS remission, rapid remission. You can use numbers to define remission, and if you apply different definitions of remission to the same cohort, you get different percentages of patients who actually achieve remission. What's the difference between them, and what happens when you look at an even finer definition of remission by looking at people supposedly in remission but doing an MRI or an ultrasound and seeing evidence of occult synovitis in such patients? Does that mean the same thing as if it's not there? So the Arctic study set out to look at what happens when you impose a treat-to-target strategy in a DMARD naive population and look at the ultimate outcomes after 2 years, and then in a parallel group do the same but also include an ultrasound endpoint. So the primary endpoint was defined as, at the end of the study, at the end of 2 years, no swollen joints and no X-ray progression. And they looked at the two strategies, one that was ultrasound guided and one that was guided just by clinical parameters. At the end of 2 years, there were actually equal outcomes. 22% of the tight control group achieved remission as defined by the primary endpoint, and 19% of those just on the clinical parameters and tight control achieved the same outcome. Other secondary outcomes were also equal between groups, and that included safety outcomes, but also functional outcomes and joint damage outcomes by X-ray, suggesting that getting finer measures of remission by using imaging may not add any additional value to the ultimate outcomes of the patient. An interesting study, and actually one that's been mirrored in another study that was presented last year at EULAR. Our next report actually is a report and an update on what's going on in the world of biosimilars. As you know, we've had a number of biosimilars that have been approved in a recent FDA hearing looking for yet more of the FDA approvals, this time with the Tanacept biosimilars. With the first round of approvals early in the year, J&J or Centocor actually went to court to show that its existing patent on Remicade, which was due to expire in September of this year, was still valid, and that these new biosimilars were infringing upon that patent protection. Turns out this week that a U.S. court affirmed that the existing J&J patent on Remicade will expire in September, leading the way for other biosimilars to be entered into the market in time to come. So this is a setback for Remicade and Centocor, but yet an advance for those who wish to develop infliximab-like biosimilars in the United States and put them up for sale. Again, it's a blockbuster drug. Last year, selling $6.6 billion worth of drug in the United States alone. So we'll wait and see how soon this will prompt the development of biosimilars in our marketplace. There's a nice report on MedPage today that we published on our site about the DASH diet and its role in gout. This was reported last year at the ACR meeting and made it into publication. The DASH stands for Dietary Approaches to Stop Hypertension, and is designed to be a diet that's used in cardiovascular endpoint trials and whatnot. The diet consists of vegetables, fruits, low fat dairy products, whole grains, poultry, fish, nuts, and when applied to a population of people with gout, it was shown to significantly reduce the level of serum uric acid depending on how high the serum uric acid. If your uric acid was low, it had no effect. But if you're over 7, it could drop your uric acid by as much as 0.5 milligram per deciliter. Interestingly, in the same diet, they showed that increasing amounts of salt intake was associated with lower uric acid levels. So an interesting study, observational study from a large population of individuals. A survey was taken in the last year looking at 600 patients with psoriasis, showing that despite their having multiple treatment options, they're really not satisfied with their current treatment options. Many patients still have attacks, or flares of their disease. Many patients note that they're sort of stigmatized, and it's a very negative thing to have the diagnosis. Only 1/3 said they were actually satisfied with their current treatment, and during the last few years, there has been a decrease in the amount of phototherapy, an increase in the amount of topical therapy, and an increase in the amount of biologics that are being introduced. Nevertheless, most patients really are dissatisfied with the treatment options they have, suggesting yet another unmet need and need for future therapy. Another report from the Veterans Administration looked at their registry of over 1,400 RA patients, and specifically looking at CCP positive individuals showed that those who were current smokers compared to former or never smokers had much higher levels of pro-inflammatory cytokines and much higher DAS scores, suggesting that cessation of smoking would be an advantageous thing to do in patients with rheumatoid arthritis. We certainly know that smoking is a risk factor for RA. We know that smoking is a risk, is also makes it harder for patients to have a significant response to both methotrexate and biologics like TNF inhibitors. So again, smoking cessation is an important part of RA management these days. A nice review of myelodysplastic syndrome patients disclosed from the literature disclosed over 30 patients with this diagnosis, and saw a variety of them who had over 30 of them who had autoimmune type syndromes. This included patients who had culture-negative sepsis, meaning fevers that were undiagnosed, inflammatory arthritis in 3, vasculitis in 4, 2 each with either pericarditis or polymyalgia rheumatica, and 1 each with either undiagnosed mouth ulcers, pulmonary infiltrates, Behçet syndrome, polychondritis, or an undifferentiated autoimmune disease. You see quite a range of manifestations leading to a diagnosis of myelodysplasia. If you read the comments section of this report, you'll see a nice report from one of our colleagues suggesting that when patients have an atypical, unusual presentation, they should be followed closely for things like myelodysplasia, and in his case, the ultimate diagnosis of leukemia. These patients with myelodysplasia and autoimmune features were treated with prednisone, with or without other DMARDs, with moderate success. From the social media feed, a number of different reports. There's a nice report from the Cleveland Clinic from Lenny Calabrese looking at the Zika virus and how it can look like rheumatoid arthritis and the challenges in making that diagnosis. There's a report from the Nimgin systemic sclerosis cohort study that looked at patients who have widespread scleroderma alone and compared them to patients who had widespread scleroderma plus an overlap with polymyositis. Now we're talking about 336 scleroderma patients versus only 24 with the overlap syndrome, but nonetheless, patients with the overlap syndrome had more significantly severe disease and a 2.3-fold higher risk of mortality associated with just having the overlap syndrome. So maybe the take-home message is that overlap syndromes are not necessarily incomplete versions. They may be more severe versions of the parent condition, whichever one that is. There's a nice report that looks at synovial fluid white blood cell counts and correlates them with joint outcomes, and it was shown in this study that patients who had synovial fluid counts of either less than 100, more than 1,000, and even higher was associated with a higher degree of synovitis on MRI and overall joint damage on MRI, so that, again, synovial fluid WBC counts can predict synovitis and damage. More importantly, that higher rates of synovial fluid white blood cells are also associated with greater responses to intra-articular steroids, which is a nice clinical pearl when considering whether or not to inject a joint. There's a nice study, for a population-based study from Canada, that showed that unhealthy habits are really quite prevalent in general society, especially in Canada, that things like smoking, bad diets, physical inactivity, alcohol overuse, on average leads to a 6-year loss of life when applied to this large Canadian cohort, and basically accounted for over 50% of the deaths in Canada. A small study of 30 scleroderma patients looked at the predictive value of serum VEG or vascular endothelial growth factor and showed that VEGF was significantly correlated with the findings of peripheral arthritis in patients with scleroderma, which I found surprising because I would have thought that VEGF levels might correlate better with widespread organ involvement or renal involvement, but no, in this study it was only arthritis. But again, this was a small study. And lastly, periodic fevers, teaching point. Most people misdiagnose Still's disease just because they have intermittent fevers, but it is the duration of the fever that lends to a possible diagnosis. So in the case of a fever of greater than 102 that lasts for only a few days, by that I mean 1 to 3 days, you should consider FMF and CAPS. That's the familial Mediterranean fever and the cryopyrin associated periodic syndromes. For fevers that last 7 to 21 days, you should consider TRAP syndrome, the deficiency of the type 1 TNF receptor that is very responsive to Enbrel. And then lastly, patients who have daily fevers, and by that I mean every day, usually in a quotidian and circadian fashion, that's greater than 102, you should consider Still's disease and or Schnitzler syndrome. That's it for this week in RheumNow. Go to the website to see the links to these reports and for more information about the wonderful world of rheumatology. You can also follow us on iTunes, where you can download this as a podcast along with the other podcasts from previous weeks. Hope you have a good week. We'll see you next week on RheumNow.